Thank you all for joining. We will get started in just a moment. All right, Dr. Amico, go ahead.
Okay, good evening and welcome to everybody. Tonight we're focusing on the wellness and interventional cardiology. Our field is a high intensity field defined by long hours, acute decision making, technical precision, and emotional weight as well. While we dedicate ourselves to saving lives, we also commit to protecting our own. Tonight's discussion will explore practical strategies, cultural change, and system level approaches that support resilience and long-term career fulfillment. Thank you for all being here, for investing in yourself as well as your patients. I think we have oh, yeah, there we go. Okay, here's our poll. Okay. So first, I have the honor of introducing Dr. Shahari Naidu, who's the SCAI President, Director of the Cardiac Catheterization Laboratory and Hypertrophic Cardiomyopathy Program at Westchester Medical Center. Dr. Naidu is also somebody who I train under and has become a source of guidance for me as well, and I really appreciate him being here tonight.
Thank you, Frank. You guys can all hear me?
Yep.
Yep, we can.
Okay, great. So first of all, this is a very important webinar. I think for a long time we've sort of neglected or ignored the aspects of service in our field. We know what we're doing and we know we sign up for Interventional Cardiology Call, but a lot has changed in the past 20 years in the landscape of what kind of call we need to do, how frequent we have to do call, what's involved in call, remuneration as well. So a little bit of, from my history, I've been at 3 different hospitals. The first one was a full academic hospital where there was 5 of us, closed lab when we were taking call, but I lived very close to home. I lived about 5 minutes walking distance from home, so literally across the street. From there, I moved to a private practice institution where Frank was a trainee. That's how I met him. But at that institution, we had about 6 people taking call, 4 privates, 2 faculty, and we rotated in. And some people live much farther away, some people live much closer, but that's the first time I had to deal with commuting and making sure you're on time for door to Boon time and negotiating those types of things. More recently, I'm at Westchester Medical Center where we have been Q5 at some point, then became Q4, and in a short time we became Q3 when we were down somebody. And so I'm going to talk a little bit about some of these aspects. These settings can be, as I mentioned, you could have a full academic setting with closed lab, with lots of fellows and different people to help. You can have a private practice setting where you do have fellows, but you may have scrub techs, scrub PAs, but you may have to live farther away if you want to have a good work-life balance, perhaps. Then you have the community hospitals where you may not have as much support and you may live in variable distances away. These each present a lot of different challenges. The things I want to bring up, number one, is that I do think, and maybe we'll talk about later, that there should be a maximum amount of call. So in other words, when we went down to Q3, we did that for a little while, but then we were about to do that again. We didn't end up doing that. But the second time that happened, we went to the administration and said, nope, if we do Q3, we need to be getting paid additionally and making Q4 the absolute maximum. So they did ultimately sign on to that. We didn't end up having to do it, but I'll give you as an example that we do have to hold our ground, and each hospital is a little bit different, but this is one area where SCAI can lead. Honestly, when you do Q4, we all know when somebody's away, you're Q3 for that time being, and then when they come back, somebody else is Q3, and so it ends up being Q3 a lot, and that could be overbearing for the duration of what we do. Number one is the call schedule like that, so we should talk about that, and at the end, I'll give you some things we're trying to do with SCAI. Second thing is something that came up that that really hasn't happened and really hasn't been talked about, which is accommodation. So, for example, we're all traveling in and commuting as much as 30 minutes to make door to Boon time. I've been commuting, and Frank knows this, for about 18 years, either minimum of 30 minutes to get to my STEMI. And so I, modify my routine and schedule so that I can make it in, and there'll be some false alarms, but in general, I'm racing in. Now, when you're racing in, you're taking on some risk, and that risk is exponential when you're fatigued. And Frank can talk about that, other people can talk about that, but in general, we all may feel like we're handling it, but sleep is sleep. It's a human function, and you may not be fully in control of those things. So one thing that I thought about that we should talk about in terms of a setting is, should hospitals provide accommodations so that you have the leeway to live where you want to live? We tend to take call and say that, well, we have to put it on ourselves to live close enough to do STEMI call. I'm not sure that that's our responsibility. It might be that our responsibility is to make sure that we can do it, but maybe they do the accommodations and not just some bunk bed in the basement, but rather accommodations befitting an interventional cardiologist like they do for locum people. A lot of locum people's doing this stuff, and they have actual accommodations. So that's another thing to consider. And that way, if you're tired, you go to the on-call, one bedroom or whatever it is. As opposed, hospitals can probably afford this if we mandate it and we discuss it as an institution such as SCAI. So that's the other thing, and that would probably eliminate some of the fatigue aspects, because you can make a decision. I'm tired tonight. I was on 2 nights in a row. I'm going to stay at this time and not have to deal with it in the morning. The other setting is how often people are doing it. Even if it's Q4, it can vary in terms of, is it every fourth night? Is it every fourth weekend, or is it every fourth week? At my previous hospital, we did a week at a time. And I will tell you, it was brutal. Frank probably remembers this. We had a lot of STEMIs, and I was probably doing, 8 or 9 or 10 on the weekends. And then there's some nights where you have back-to-back on-call nights, which are horrible. It's not so bad at my current institution, but these are setups for, disaster. And so what comes of that is, which setting is better for your facility and for your colleagues, but also how do you have pop-off valves in 2 ways? One is, can colleagues swap or cover if you get hammered 2 nights in a row, for example, or you're tired or you're sick. And the other aspect of that is, what do hospitals do, or what should they do, or what could they do to make the next day easier? Now, that's controversial because you may book cases the next day and you don't want people telling you not to do that. But it's also entirely possible to modify schedules so that you're on call before being sort of in an easier, lighter schedule the next day, an admin day or a clinic day or something that could be modified a little bit different than cutting edge techniques. The other aspect that I think should be discussed is remuneration. So in the past, they kind of benchmark what interventional cardiologists make, but that number has come down quite a bit and is very commensurate with non-invasive cardiology. So in my opinion, there should either be a sizable bump for this, or they have to pay for call just like they pay for nurses on call, where you're on call carrying, kind of on call, and then when you come in, you get additional salary for that. Some places do that, some places don't, but there should be some uniformity in my mind. And I do think that in the era of RVUs being the king, the RVU you get for a STEMI at 3 a.m. is not going to cover the amount of work that you're doing and the hazard to your body and your family and these things going forward, when remuneration is about the same as non-invasive cardiology. The last aspect I'll mention is that different hospitals do different things. We think about STEMI call, but nowadays call includes a lot more things. Probably we come in half the time for shock work and for mechanical support and hemodynamics and things like that as we do for STEMI. And then now we're being asked to come in for PERT. We're being asked to come in for TVPs, of course. And so the breadth of what we're doing is increasing, which means that we have to have discussions about what is reasonable to do on call, which competes with STEMI care. How do you manage multiple cases at the same time? If that happens, it's more likely to happen. Or do we say that some of these things do not happen off hours unless there are certain criteria met? So I'm going to kind of end there, because what I'm trying to do is, I know Poonam and Allison know from the Wellness Committee that when I took over as president, this came up, and I wanted SCAI to have some statement here. So the Wellness Series is one of the ways to gather data here. But then also the goal in my mind is to put together some kind of white paper or document that outlines some of these aspects, at least some preliminary discussions, that can give people something to use to negotiate and take back to hospitals for some guidelines and what's reasonable, appropriate appropriate, safe and efficacious on-call in the current and future era. So I will end there. I don't know. I can't stay, unfortunately. I have an event to go to. But if there's any questions now, that's fine, or I'll leave it to Frank to moderate. Thank you.
No, I appreciate. I agree with everything you said, and I just want to briefly just mention. I don't want to belabor it, but so I agree with Dr. Naidu. But so, for example, I was on call for a whole weekend. We did about 14 STEMIs and suffered a spinal cord injury, and now am living with the consequences of that. So I agree with everything you said, including, like, for example, accommodations. Remuneration is, while it's important, no debate there. To me, it's more about preventing anybody from experiencing what I'm experiencing, and I'm blessed. Don't get me wrong, I'm not complaining, but it is definitely a challenge, as Dr. Naidu knows, because we will communicate about this in general. Just on an off level kind of conversation. But so yeah, no, I agree with everything you said. I don't know if anybody else has anything else to add to that, Dr. Butch or Dr. Vilagudi.
I think I kind of agree. Actually, I will present some data, but the percentage of people doing call at 1:4 is about 20%, 1:4 or less. So if you have about 7 to 10,000 interventional cardiologists, you see the number of people who are doing a call that's less than 1:4. And, I think that's a very important point about accommodations and having coverage.
When you're saying less, you mean more, right? 1 in 3,
correct.
meaning less, meaning more. Right?
Yeah, a smaller ratio, meaning you take more call, and then when somebody's gone, and then you feel the brunt of it, and really no solution to that. But I'm going to present all this. You went before me, so I'm going to present some data and some more slides. But I think you pretty much covered a lot of ground.
So just on the off note, I just want to welcome everybody, get everybody's opinions. Like, for myself at least, there's like I think we spoke about this yesterday, that there's like this adrenaline rush, right, for STEMI. Like, so for example, you have this, like, we got to go, like Dr. Naidu was saying, 30 minutes, etc. And then after it's done, it's a drop. And like, for example, I didn't realize I was tired. I didn't realize, I mean, I was like, I'm good to go. And it's just one small little nod off around a turn and you land up in a ditch, literally. And life has changed forever. And that's okay, dealing with it. But anyway, so I think we can move on. Thank Dr. Naidu. I appreciate you making time. Seriously, I mean that. So next I'm going to introduce Dr. Velagapudi, who is the co-chair. If I'm wrong, I'm sorry. Let me pull up your very short bio.
Oh, the SCAI Wellness Committee.
The co-chair of the SCAI Wellness Committee. So she'll kind of talk next about the Bane and Boon of Interventional Cardiology Call, the Boon and Bane.
Yeah, I'm going to share my slides. Okay, can you see my slides?
Yes. Yeah.
Awesome. So I just want to throw in a plug why STEMI call is so important. We see that mortality over the years, men and women, 2 to 3% from STEMI cases. And then when you combine STEMI with shock, as Hari was mentioning, you have mortality that is 30 to 50%. And usually women probably have worse outcomes, and timely PCI and mechanical support in shock cases where we need them is extremely important to save lives. And so, which is the reason why a STEMI call is important both for patients as well as hospitals and physicians practices. So I was asked to talk about the boon and bane of STEMI call, and I think it's a big boon for patients. There's about 8,000 ACS cases in the United States, and of which 30% are STEMI. So probably about 250 to 300,000 cases. And time is muscle. You want to do the primary PCI within 90 minutes. And with all the systems and us being on call, the mortality from STEMI is actually decreasing and probably has plateaued for a little bit. But it's really important that we understand the physician aspect to call as well. And this is just one of the studies that shows how mortality has decreased over the years in both men and women due to all the good things that we've been doing for STEMI patients. And so it's time to talk about how this is a boon and a bane for interventional cardiologists. So in a way, having STEMI call is probably a boon for all of us, because if we have one partner who's on call, then the other interventional cardiologists can really have an uninterrupted schedule. You could do your outpatient cases, you can be in clinic uninterrupted, or you do research or teach or give lectures. You can do all these things while somebody else is on call. Now, an interventionist on call is also available for other interventional emergencies. For example, if you've done a case and you had a complication, it's probably your partner who's on call is able to handle that. So that may vary between an academic and a private setting, where you may have fellows, or you may not have someone, but definitely having a colleague on call who could answer those emergencies is really helpful. Now, in some centers, ICs also do general and take imaging call. In those settings, the other people also benefit from that. It's not just specific to interventional, but I'm just mentioning it because they're also benefiting the group as a whole. And then some centers do pay some additional compensation, may not be a whole lot, and may not really be worth the time you spend at night, but it's something of a benefit for those who take call in some centers. Now, STEMI call is also a boon for hospitals, because once you have a 24/7 STEMI coverage, then these hospitals are designated as STEMI centers. And so you're going to have referral networks, and this helps increase patient volume and build relationships. And over time, you're actually getting more patients, and you're able to build these relationships with other physicians around the community. Now, there's this observational study. This is not in the US, but this program implemented a STEMI hotline versus just a routine referral. The STEMI hotline was monitored 24/7 by a cardiologist, and anybody could reach this hotline, from clinics to local health centers to hospitals, with no delay. And then they immediately sent the EKG to the interventional, and then the STEMI was activated. So they saw there was an increase in about 14 to 41% increase in referrals from private clinics and other hospitals around. And even from local health centers, you have an increase of 3 to 14%. That's what they saw compared to the routine referrals. So it helps hospitals to establish as a specialty center. Now, I want to touch a little bit upon this important slide on the cardiology workforce in the United States. This is really important and has been discussed in multiple venues. Our practicing cardiologists, based on several MedAxiom survey, is about 30,000. And of those, about a fourth probably are over age of 60. And then the annual departures are estimated, they're about 2,000. The current US fellows training are about 3,500, and then the annual number entering the workforce would be about 1,500. So overall, a net negative of about 500 on an annual basis. And you can look at the pie chart, which shows the age distribution of these cardiologists. This is overall cardiology, not just interventional. So you can see about a quarter are over age 60. So we are going to face a deficiency in cardiologists over the coming years, and a huge deficiency is predicted by 2050. So what happens when these people start, slowing down or retiring? The first thing an interventional cardiologist, will probably give up is night and weekend call. And then this burden gets onto the other members of the group. And the daytime practice pretty much stays intact because they're still working during the day, and then you can't hire new people. So then the burden of call is increasing on those who are actually still continuing to practice full time. So I just wanted to show this because it's so important that I know we talk about training a lot of interventional cardiologists, but just overall in general, cardiology itself may face some deficiencies over the coming years. Now, why is STEMI called a Bane? Again, it's a Bane, for multiple reasons. The first and most important thing is time. Time is the most precious commodity that everybody will agree with that statement, I suppose. And based on this survey, you can see this is a mid-axiom survey of the IC call pay for 2024. This shows that the frequency of call less than 1:4 in about 20% interventional cardiologists for weekdays as well as weekends. The others are, you can see 1:5 or more than 1:6, which is manageable, but less than 1:4 would mean you probably are on call more than once a week. So being on call is a significant reason for burnout in physicians. This was a survey that was published by Dr. Simsek and group on psychological well-being of interventional cardiologists. And 50% of the respondents were from North America. And, the survey said, the respondents said over 3 times, being on call more than 3 times a week is more, those group are more likely to be burned out versus those who are on call less than 3 times a week. So 74 versus 66 with a significant P. So it's probably not the primary outcome, but it's one of the questions that was asked in the survey. And I thought it was interesting because if you have 20% of the people doing more frequent call, then I can imagine what the burnout rate would be over the years. Now, in terms of health, taking call means additional time in the lab. You're only coming in mostly for the STEMIs and high-risk cases, so which means you're going to be in the lab, you're going to be wearing lead, you're going to have radiation exposure. So the same things that are related to interventional cardiology would relate to call as well. This is a survey that we did, SCAI did on the occupational health hazards, and we sent the survey to multiple people, not just interventional cardiologists, but everybody. But we did have about 7 to 8% response rate. And you can see that 6% had diagnosis of cancer, 5% cataract, either themselves or somebody they know, and then 5% with skin disease. And the orthopedic stuff is quite high. 66% had musculoskeletal pain due to wearing lead. 34% had lumbar spine injury and 25% cervical spine injury. And in pregnancy, pregnant ICs were discouraged from working in the lab just due to being pregnant. So health-related issues are not inconspicuous. Now, another one that Hari had mentioned is sleep. One of the most important things is when you get called in, then your next day is going to be a full day, just like usual, and nobody's giving you a post-call day off, as in training, right? And so it really has all the negative effects of sleep deprivation can be seen. So, this was very interesting, and I thought I should show you is that what we're working for is you try to reduce cardiovascular disease, but then sleep deprivation itself can lead to cardiovascular complications through endothelial dysfunction and some of the other pathways that have been described here. Now, there is on the right side, I just want to show you the survey of about 500 cardiovascular workers, of whom 70% of these survey respondents were ICs. And they showed that responses show that sleep deprivation was associated with difficulty concentrating, lack of motivation, irritability, felt work performance was hindered, and felt burnout, all these 50% or more. And 85% thought that they should, if they felt sleep deprived, they should be able to go home early post-call. And a very surprising high number, 8.5% reported an adverse event, such as a complication or negative patient outcome likely related to sleep deprivation. So I've just summarized all these things and just talk about all the reasons why IC call can not be the best for personal or professional reasons. So your time with family is cut down. Your health, may be affected. For interventional cardiologists who take more call, have sleep deprivation, and then orthopedic radiation injury. Eating habits get all messed up. Loss of fitness routines. Don't have time to do the fun things that you like to do. Or driving at odd hours, just as Frank just mentioned, and the related risks. Now, I have had a friend during one of my training years who was on call and was driving the next day. She slept at the wheel and she was on the other side of the road, and the car was really bad situation, but she survived it without a scratch. So I'm grateful for that. But we've all seen or we know about some of these things, and so it's really important that sleep deprivation is tackled appropriately when we have people doing call on a routine basis. Now, professionally, fatigue can affect complex cases. We all know sometimes cases can take long, CTO cases, for example, or some complex interventions. You spend a lot of time in these, and if you're post-call and you haven't had a good night's sleep, I mean, imagine on a routine day, they can be complex, and then this just adds up. Now, when you have illness or somebody's gone on vacation or post-call days, all these days, you just decrease productivity. And if you're not allowed to be in the lab during pregnancy, then that is also leading to decreased productivity. And then ICs might retire early to avoid taking call, and they start doing general cardiology, then you're losing some important cardiovascular workforce where we really need them. For system-wise, coverage gaps are really hard to fill sometimes because, if somebody goes on a long leave, or it just puts more work on the remaining folks who are available, right? And then the intensity of call increases when you have fewer interventional cardiologists. And then obviously the system has to spend more money if you want to bring in more people. And that itself adds a burden to an already existing, burdensome stuff. Now, for patients, they may not be able to see their regular doctor sometimes. Let's say somebody is not, not able to perform, or they want to leave early or something, and they just may not be available. Or they may be seeing an overworked physician and who doesn't have enough time for pre-post discussions as somebody who had a good night's sleep or who's, had a routine day. Again, these are all not that you'd have them every day. It's not like you get called in every day, but these are over the years probably, and it's sort of an accumulative thing that we keep in mind. There's several models of STEMI call, and as Hari was mentioning, it could be a Q frequency-based model. So my personal story is that I've trained at Brown University for my interventional cardiology, very busy for STEMIs. We would have 300 to 400 STEMIs a year, and we were on Q2 call. And one of them was primary, the other was a secondary call. But there were a lot of times when we would get called at both hospitals at the same time. So it was a lot of sleep deprivation, but it was always you're younger and you just have a lot of adrenaline and you get going with it, but you can't sustain that kind of a model for a long time. But that was because you're in training. But once you're out of that, you probably won't be able to sustain this sort of a call for a long time. Then I trained at Columbia, where it was a much less frequency of call, and you just kind of went in once in so many days based on the number of trainees. So that was a Q4, 5, 6, or whatnot. It was a good frequency of call. And then I worked at a university system at University of Nebraska that, we had a huge referral system, also not a super busy STEMI center, but cases were very complex, I would say. So the times you get called in, you're spending not just during the case, but you're also responsible for the patient until the next morning, until the team takes over. So you're just spending a lot of time when you see such complex patients. And then I did locums for a while. And during that time, I've seen the practice in the community setting where you really don't have fellows or residents or anybody, and you are the person. And I've done call for a whole week, or I've also done system where you take call once in a couple of days and a couple of weekends. So there's different kinds of systems, and I've listed those here: the weekly block model or frequency-based model, mixed models. There's some systems that also have a night float, where you're probably more common in internal medicine, where you do only nights. That's probably less common in interventional cardiology, but that's just an option. There's a compensation model where those who offer to take call are paid an additional fee. And there's the locums model where you have a locum for a couple of days to help your regular staff. So there is not really perfect model. It just depends on the group size, the volume, the geography, and then also how much the program is willing to spend. And it's mostly determined by the number of interventional cardiologists and your STEMI volume. For example, when I was in one of the programs, I knew there was a private practitioner who was on call almost every day for his patients. So, I mean, which can be quite stressful. And really, these are the things that might reduce the amount of time you may actually work, which affects the cardiovascular workflows as a whole. So I'd like to conclude by saying that STEMI call is a backbone of interventional cardiology practice that saves patients' lives. There is no question about that, and this is not going away anytime soon. It has direct effects on interventional cardiologists, but also indirect effects on their families, their patients, and the system. There's several models of STEMI call. This can be determined by practice size, number of ICs, finances, maybe even geographical location and type of practice. And the solutions for improving IC work-life balance are extremely important for continuing this important STEMI call system. And I think Hari had touched on a lot of things. And he was supposed to go after me, which is why the solutions came first. But I think a lot of things that he touched really are important things that I think we can talk about or discuss. So thank you.
Thank you very much. So, I don't want to take too much time because I want to open it up later on. But, it's interesting. I think a lot of the points you make, especially like orthopedic injuries, cataracts, and I think we've had this discussion also. It's important. Don't get me wrong. Of all people, I'm not trivializing that. However, I think what's also lost in life is relationships or hobbies, which you mentioned. But I think that again, I would never trivialize someone's injury, traumatic injury and all that. But I think we also have to not forget the small things in life that matter, because I'll give you just a quick example. I wanted to take my son every to a different national park every summer. I'll never be able to do that. Not the way I wanted to, at least, not the way, and then that's okay. Again, this is not Frank and Miko complaining. This is just explaining what life is like after dedicating yourself and getting injured in interventional cardiology. So I think, let's not forget, and as you mentioned, and you covered very, 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 very thoroughly, the small things in life too, right? Like just being able to have a baseball catch. Can't do it. And it's hurtful, and or like when it snowed in Virginia like twice, or every so it's here and there. Anyway, point is like he's like, let's go play in this. Dad, you can't play in the snow. Can't do it. And again, these are things that we shouldn't take for granted. I mean, don't get me wrong. I moved out of New York for a reason. I don't want to play in the snow, but I don't want it to be for this reason, right? So, all right. So let's move on to the next speaker, who is Dr. Butch, who trained in England and then trained in MedStar in Washington, D.C. Also worked at East Carolina University as a predominant trainer for interventional cardiology fellows there. Currently working at Chesapeake Regional Medical Center. He has one big achievement to mention. He trained me. So anyway, so Dr. Butch, please take it away.
I will. Thank you very much, Frank. Kirsten, Laura, do you think you want to do, before I do my talk, do you want to do the remaining poll questions?
Yes.
It actually follows really well from Poonam's talk, actually, which, by the way, was excellent.
Yeah, it was very thorough, so I appreciate it.
I'll say a bit more about that in a moment. So I'll let the participants answer these questions because it's quite relevant.
See, I mean, this alone, sorry,
90%.
I
That's a
mean,
lot.
isn't that alone is disturbing, you know? And
Yes.
so here's the deal. Like, you may, I remember like 3 months after my accident, one of the other interventionalists I know flipped her car. Thank God she walked away from it, right? Without any injuries, thank God. But you never know. You know, you think you're invincible. I mean, I had a house collapse, no joke, a house collapse on me when I was a fireman, and I had a traumatic brain injury, and I still went through medical school, et cetera, and so forth. And then lo and behold, you know, just this small little nod, and you know, life's different.
So I think that the answer to that question, I think nearly everybody, if we're being honest with ourselves, if you think about even before you did interventional cardiology and you do really long on calls, we do notice some form of impairment. It's real. Is there a final question, or is that the final question? I just want to check.
There's one more.
Okay, yeah.
As we're waiting for them to answer, I guess, may I pose a question that people may be able to put into the chat, or is that okay?
Yeah, please.
Okay, so I guess the next, as we're waiting for this, I guess I would like to know if hospitals have accommodations for you as an interventional cardiologist, because that would make, I would like, for example, I live 30 minutes away. I did 13 or 14 STEMIs that weekend. Think about it, like back and forth, 30 minutes each way. I mean, you get no sleep.
Again, yeah, exactly.
90%.
90%. I think I pretty much put it, I'm not a betting man, but if I was to bet, I would think that if you had mandatory responses from all the interventional cardiologists in the USA, you would probably get similar. So without further ado, Poonam, your talk was excellent. It had some great data to highlight what actually those polls bring out. So there's enough empirical evidence to support what we're talking about here. So I'm just going to share my screen. I have got no data compared to you. Okay, so let me just make sure you can see it. Okay, everyone okay there?
Yeah.
Yes, perfect.
Right, absolutely. So disclosures don't really pertain to this. So the challenges really, let me just move this out of the way. First of all, as I see it, there's no agreed enforceable national standard for maximum allowable frequency of IC call index institutional volume. And that's in contradistinction to other countries and other systems where it can be mandated that you can only do a certain amount of call. And there have to be a certain number of interventional cardiologists, et cetera, As both Poonam and Hari have pointed out, we are a vast, varied nation. We have metro centers serving millions and millions of people, and then we have centers where the nearest large hospital is hundreds of miles away, potentially, or very far away. So there's a variety of clinical settings: rural, remote, lower volume institutions to high volume tertiary centers. And the old Seaport data showed that doing PCI in lower volume centers was safe and sort of allowed the expansion of primary PCI in these lower volume centers. But the Seaport studies from a decade or two ago, I think, really was before we had such intensive treatment of cardiogenic shock and so forth. So this is about solutions. I think it could be said that institutions and physicians should agree a maximal call frequency. And if you do a 1 in 4 and you're covering vacation, you're effectively doing a 1 in 3. So your rota is whatever it is with prospective cover for vacations, etc. So I would say it's a 1 in 5 with cross coverage, which takes it to 1 in 4. But no more than a 1 in 4, because any more than that, and you're essentially doing stretches of 1 in 2. The outliers are these remote hospitals. I know people who've done locums in remote hospitals, and they'll do 10, 15 days a stretch, and they hardly get any STEMIs, and so therefore it may be justifiable. Whether, I'm going to pose a controversial question, whether those centers should now continue to, given that if a patient gets admitted there with cardiogenic shock, they'll have a much worse prognosis than if they're airlifted to a large center, is worth discussing at a national level. There's a good case for saying that STEMIs should go to the larger centers where all patients, regardless of where they live in the USA, are able to access optimum care. Most patients don't present with shock, but when they do, they're much better off going to a large center. But that's something for discussion. While we're talking about policies and working out how we can influence administration and what with SCAI guidelines, as Harry and Poonam and all of you are doing, what can people do now? Well, graduating IC fellows, if you're on the call, you have choices. Okay, you have choices, and when you look for a job, there are various factors. You look at the pay, you look at the geography, you look at where you want to live, what sort of lifestyle you want to lead, where your family may be. But it's really, really important to look at the frequency of call. And when you're young, as Frank has alluded to, as stated in this talk, you can feel bulletproof, untouchable. But the reality is the thrill of going in for STEMI call rapidly wanes off, even for all of us. You get used to it.
But you can feel free to add your no, you can feel free to like what you're just remember when I took a job and you're
no, absolutely no, yeah. So when Frank left ECU, we kept in contact, and our relationship was more from being me, his sort of boss and trainer, to being a colleague and friend. And when he worked for a large institution, not Chesapeake, I was seriously concerned about their call schedule. I genuinely think a no-go. I advised all my fellows really not to take a job where they would have to cover STEMI call in more than one hospital. I think that should not be allowed.
Yeah, so we covered 3 hospitals when we
because when you have simultaneous STEMIs, it is absolutely impossible to guarantee good care. It won't be. It won't be ideal care, and it's a fiction to say that we would. So at the moment, there is no national way of compelling institutions, a place to do that, but fellows and doctors can make their choices by not working in such places readily. You can protect your health. So I would say to fellows, look very carefully at the call schedule. Avoid places where you have to cover multiple hospitals on call. There will be a clinical event. Avoidable clinical event will occur if you do that long enough. It's just a fact of life. So that's the first thing. Think about your choices and prioritize your health, because one of my mentors at my first attending job, I was at University Hospitals in Cardiff, said, Ash, it's a marathon, not a sprint. And that is really true. You've got to want to do this for many, many years and to do it with joy. Hari mentioned this, Poonam mentioned this. Moving on from what I said before, I think while we're trying to work out national guidelines, within each institution, there should be an agreed approach to call fatigue during IC call. So if you're doing an on-call, and let's say it is particularly busy, let's say you work in an institution where you do a 72-hour on-call. You start Friday and you finish Monday morning, and normally it's okay. But what if you have a situation like Frank's? Frank won't like me saying this, but I look back at that STEMI call weekend and I kick myself. I feel I wish I should have just called him up and say, hey man, let me take over and call here. But it doesn't occur to us. Why doesn't it occur to us? We all think we can get on with it and do it. But I think the one thing I taught when I was teaching IC fellows is recognize your own fatigue, recognize when you're tired, and recognize when you probably shouldn't carry on. And this is easier in closed units, I suspect, where there may not be competing groups, but I think it can also occur in the majority of institutions where you have multiple different groups. We're all doing this job. We're all going to get tired, and we should be there to support each other. And we should all be encouraged to say, call up our colleague and say, I've had no sleep for 24, 36 hours. Do you mind taking over? I'm going to come up with another potentially controversial idea. Let's say nobody can take over and you've got someone who's really, really, really tired. Maybe that institution has to go on divert. Should that doctor really carry on treating STEMIs when it's abundantly clear they're too tired to make clear decisions? So that's just something, food for thought. We've talked about this. Hospitals must provide comfortable on-call rooms. And I actually like Dr. Naidu's idea. We spend a ton of locum throughout the country in various institutions. We pay for their travel. We put them in hotels. They can definitely provide comfortable, decent, more than rudimentary on-call accommodation for their full-time staff. That would make a big difference. I live 30 minutes away from Chesapeake Regional Medical Center, and I have thought about contingency plans when it gets busy to have an overnight bag and check into a local hotel, so I don't have to drive up and down each time. But there should be some readily available contingency for that. And I think it should be mandatory. I think it should be absolutely mandatory, so people don't have a way of decompressing and alleviating their fatigue. Transport. So you've had a really, really tough night on call. Should you drive back? Well, I can tell you, I personally think if you're too tired to drive, you shouldn't. Now, in the United Kingdom, a doctor was jailed. A doctor drove home after a night on call, not a cardiologist. They were in a road traffic accident. I can't remember if it was fatal or non-fatal accident, but basically, this became a legal case and this doctor was found guilty. And so there are, it can have significant legal repercussions. We're responsible for our actions after call. And so I think if we know that we are so tired that we shouldn't drive home, we should be able to get a taxi, but I think the hospital should reimburse us. That will avoid potential scenario of driving on a highway, falling asleep, and potentially having an accident. I remember in the mid-90s driving back from, in the UK, back to my parents' place, and I was on the M6 motorway, and for a microsecond I nodded off. And I had a really, really busy weekend. Now, I was lucky, nothing happened, but it does happen. So within the setting of STEMI call, I think this is something that should be available. If you're too tired to drive, it is the responsible thing to do. Leave your car there and have transport back. Finally, patterns of work after IC call. Poonam went through this much more comprehensively than I have here. But there are various approaches. I personally think that if you work in an extremely busy institution, you should have the day off. One idea that does work, and we've done here, is that we either have, if I do a couple of days in a row, I'll either have the day off, but otherwise we'll have a half day. I'll do a half day clinic. And that may be a way in which someone knows that they have the half day off to go home and rest and come back the following day. Most people in most institutions, I think if we had that poll question, probably work the whole day the next day after on call. But it is incredibly fatiguing. And I think given the fact that we're going to have an attrition rate of cardiologists in the not too distant future, and those remaining are going to get busier and busier, we're going to have to work out how to deal with this now. Otherwise, we'll have more problems with fatigue doctors and avoidable events. So that's really about it for me. It was scarce with data, but Pudam did all the hard work with all the data, and Harry did all the hard work with telling us what SCAI might be doing. But thank you for your attention, and put it over to questions.
Thank you. I appreciate it. So, one thing Dr. Naidu did mention, sorry, was, the RVUs being the king, right? Dr. Butch would know this. I don't want to go into too much detail, but I was out for 6 weeks getting intravenous antibiotics because of complications from the spinal cord injury. So if you just take that 6 weeks, right, and you plug it into, let's say having a day off after call, right? I mean, I can't imagine it being, especially, I mean, all the patient rescheduling, right? I mean, all the stuff that occurred because of that illness, and on top of all the other illnesses that I had afterwards. But anyway, we got to consider what are the consequences of an accident. When I say accident, it doesn't have to be a motor vehicle accident. It could be anything, like or a complication, like orthopedic injuries, like Poonam showed. And I think you take that into consideration. Long-term productivity. I'm blessed. I have made a significant recovery that I've returned to work full time. I'm doing pretty much everything that I did before. But I don't know if that makes sense, what I'm trying to say. Like basically the long-term consequences. And secondly, the fact that stuff is moving into the cath lab more. So, for example, Impellas or ECMO, right? I know Dr. DuPont does ECMO. So that is additional demands. So I think, these are things that we have to realize and take seriously.
So, Pudam, do you want to go ahead if you want to comment on that?
Regarding what is it?
So productivity, in other words, day off after weekend on call, you're less productive. RVU hit, should you be penalized? We're quite a valuable resource, and they're going to have fewer of us.
Yeah, I think it depends on the system. For example, if you're in an academic setting, really your RVUs don't, not every academic is the same, but RVUs really aren't that much of an ordeal. But then there's some where RVUs do matter. But I think that, even if you don't get called in, maybe there should be a way of compensating, may not be financially, but maybe RVUs when you take call, because that's definitely very different than some other calls where you really don't have to go in essentially, right? You're
You can read. How about reading
always,
from home? Reading
exactly,
from ECGs. The only thing I will say, everyone, and I'm sorry to break from physicians here, is having my own personal experience with this is I'm not saying remuneration is not important. Let me be clear. But your health is way more important.
It is more important.
Trust me that. Like I don't know how to express it, to be truthful.
It is. I think it is because Frank has suffered what was a catastrophic spinal injury and has done very, very well. But if you look at the majority of interventional cardiologists I know in this country and around the world, most by the age of 50 plus have orthopedic issues, back pain. I know of someone not in the UK who's having to take not in the US, who's having to take considerable time off because of their back pain. And they're highly trained, they're skilled, they're doing something that's quite specialized. It does impact on the service. There are things, radiation protection in the lab. It's difficult to do a lot of interventional procedures without wearing lead, given the nature of what we do.
Actually, how about what is it?
Zero gravity.
Yeah.
So there are things that can help. That the hospitals need to invest in that. But I agree. I think that's why I've always advised fellows, trainees, prioritize your health. as much as you can, because the health is something that once it goes or it suffers, it's difficult to recover. I've just noted there are some. Do you want to take some comments on the
I didn't
webinar
see
chat?
it. Sorry. Okay. Thank you. Calls are you.
Comment on this. So the first comment was comment on the situation that there are hospitals where not all IC on staff share the STEMI call. Should there be a recommendation that all ICs should share call? I think so. Or if the ICs take call should have different schedule, i.e. mandated less than regular clinical activities and post-call days, or even day off extra PTO besides different additional compensation. Yeah, there are some places where different groups just run their own IC call. Personally, I think if a hospital has a STEMI program, everyone has to take part in it. And the worry that people are taking other people's patients comes out in the wash because we all treat each other's. Poonam, what do you think?
I think so too. I mean, I've always seen interventional call distributed equally between faculty. The only reasons they may not be is people may have become part-time or less clinical, and they've already accepted a less, payments, less compensation. But also, I've noticed, like I said, I've done locum. So when the locum's available, I've done at one facility a week of calls, so day and night, which is the most stressful. I mean, even, you just, even though you're not coming in, sometimes you get woken up for looking at EKGs and stuff. And so to do that on a continuous basis is not really the best situation. So I think call has to be equal. And if you're paying a locum more than your regular provider, that's not the best thing. I think everybody should be probably equally compensated for call.
Yeah. There's a question here from Dr. Gilchrist, Ian Gilchrist. Do you really want a 65-year-old IC on the same shift as a 35-year-old? No. I mean, I can, we haven't got many minutes left, but not to reference my country of origin, they're actually starting to come up with policies, visas, for 55 and above to not take night call, if I'm correct. And definitely 60 and above. So I think that's something that has to be talked about. It does impact service provision. It also impacts what hospitals can be STEMI centers, because you probably need a higher concentration of higher numbers of interventionists.
So I think good points. But one thing you mentioned that I was interested in, I know that we've had this issue at Chesapeake. Poonam, what do you think about divert? So like for example, that weekend I had a call, I was like one after another. It was ridiculous. The first one was a long case. It was a cardiogenic shock case. But anyway, point being, what do you think about diversion?
So
Hospitals
it's
like it, but
yeah,
it's
it's an
private, but
important one, right? Yeah, you want the best for your patients and for your physicians as well. A tired physician is not going to be the best person to take care of a sick, STEMI patient. For example, I can give you one example where I was covering for a system where docs are about 30 to 40 minutes away, and it's a bad winter storm or something like that. You can expect people to come in, and especially when they're covering two hospitals. If you're covering one, maybe you can decide to come in and stay that night and then be done with it. But if you're covering two systems, you have to divert, right? It's for the safety of the people who are driving in. They just can't drive in a bad weather. A 10-minute drive could take you 40 minutes, and in slick conditions. So I think it's really important that there has to be a diversion system, and that's why we have the STEMI network.
So the reason why I mentioned that though is because if you think about it, so Ash, let's take you and I, right? I'm on a STEMI call. I get a lot of STEMIs. You're still on call theoretically if you're backup, right?
Mm-hmm.
So therefore, you'll never truly get that time of like, I'm off, it's cleanup time and all that stuff. All of this, like, there's never a time when you're really off if there's backup. So, for example, that's why I bring up diversion. You can divert if you get a lot of STEMI, especially like when it's us. It's like it's me. What is it? There's four of us. There's four of us, and it's not a terribly busy center, but it could get busy. It's not. So that's why I mentioned diversion.
Yeah,
Because at the end of the day,
absolutely.
then you'll never really be off.
So I think it's 6:59, and I think Poonam, you also have to take off. Frank, do you want to do some
Sorry.
closing remarks?
You know, my closing remarks would be, basically remuneration. Again, one thing I'm kind of sensitive to is remuneration is important, but your health is number one. You'll never, if you, I don't want to see anybody suffer and be hurt because of their dedication to the job. Um, so that's really, you know, yes, that's all important, but I want everyone to really seriously consider when it's safe to do what we do. And it's not easy to do that. It really is not. It's not easy to do that. But I think just God bless everyone. And I hope everyone be safe and just take this into consideration and learn, you know, we can learn from everybody, right? I've learned from you tremendously, but now you're learning from me, you know, and I said that to my father too when I was sitting in, I'll never forget those times. But anyway, I just think that yes, pay is important, accommodations, all this is important. And this is stuff that should be raised. I think the divert is really actually extremely important. But first and foremost, protect your health. It's the golden thing for you.
Okay, thanks, Frank.
You're welcome. I mean, I think we, I think, this is, okay, let's see. I think we're pretty much done. I don't know if anybody else has any questions. Kristen, I don't know if you have anything to add.
No, we can go ahead and end the webinar. Thanks so much for being here, everyone.
Yep.
Yeah,